Good morning, everyone. Good morning. Good morning from New York, and good evening to those on the other side of the world. I would like to welcome you all to today's session for the INEDSYS. And we have today Dr. Ethan Weinberg. Dr. Weinberg is going to talk today about Ascites A to Z. Um, Dr. Weinberg is an assistant professor of clinical medicine at the University of Pennsylvania. He completed his internal medicine residency and gastroenterology fellowship at Weill Cornell and postdoctoral fellowship at the Rockefeller University, New York City, prior to joining University of Pennsylvania in 2016. The focus of his research in the Division of Gastroenterology and Hepatology in the Perelman School of Medicine at the University of Pennsylvania is in clinical trials and clinical studies for the treatment and advancement of liver disease. He's engaged in industry-sponsored clinical trials, investigator-initiated clinical trials, and multi-centered consortiums focusing on range of liver diseases and complication of cirrhosis. He's dedicated to innovative treatments and diagnostic for liver disease through both novel therapeutics and the repurposing of existing medications. In 2018, he was awarded the AASLD Autoimmune Liver Disease Pilot Research Grant and named an inaugural fellow in the Clinical Trials Fellowship of the Institute for Translational Medicine and Therapeutics of the Perelman School of Medicine at the University of Pennsylvania to support his investigator-initiated clinical trial to evaluate the efficacy of ursodeoxycholic acid for the treatment of hepatic sarcoid. He has served as a site principal investigator and co-investigator on clinical trials focusing on hepatitis C, fatty liver disease, acute and chronic liver failure, hepatorenal syndrome, decompensated cirrhosis, and alcohol-associated hepatitis, in addition to that, PBC and PSC as well. With that introduction, I would like to welcome Dr. Weinberg and hand it over to his presentation. Dr. Weinberg, please take it away.
Thanks, Sanjay. I'm delighted to be speaking in this forum today. I'm going to be speaking about ascites. I feel like it's something that as hepatologists we see all the time, and we feel like we have a good handle on it. But there are lots of nuances and understanding the sort of disease process better, and there are things we can do to improve on how we take care of our patients. If we understand the disease better, understand the phases of ascites, and sort of it's not just give someone furosemide and spironolactone and call it a day, or paracentesis. So here's my presentation of ascites A to Z. These are my disclosures. So we start with at risk. Can we determine those who may develop ascites and try to prevent it from occurring? How do we diagnose ascites? This is where paracentesis comes in. Eating, since this is where we provide you some data about salt restriction. F is for furosemide, the medications we're going to use to try to treat ascites. RST, this is where ascites has become a little bit more advanced, and we're looking at recurrent and refractory ascites. SBP and thoracentesis for the hepatic hydrothorax. And Z, I had to play around. This is the dreaded Z hepatorenal syndrome. So this is really the sort of last stage of what happens with ascites. I know this is a global audience. Most of the time I'm speaking to an American audience. And for my practice in Philadelphia, this was important to me. How many Americans have ascites? And so you can think about this, not just Americans, but the percents really apply. For us, I would say about 1.5 million patients may have cirrhosis. And that estimate is probably between, some papers will say a little bit less than 1 million, all the way up to 3.5 million. So I put it right in the middle, 1.5 million. And about a third of patients with cirrhosis will have some decompensation, with ascites being the most common. So we're looking at maybe 300,000 patients with ascites. And those with refractory ascites, though in clinical practice it may feel like a lot, it actually isn't. It's usually about 10%. But people are in flux. People are moving through that spectrum at all times. And why should we care about ascites? It's really because ascites foreshadows poor outcomes, death for our patients. So this was a great paper out of an Italian group, just showing that if you your transplant-free survival, if you just have cirrhosis without ascites, is pretty good at 5 years, about 80%. Whereas if you have grade 1 ascites, that's just ascites seen on imaging. Or if you have grade 2 or 3 ascites, that's ascites. Grade 2 is if it requires medication, and grade 3, usually a larger belly requiring a paracentesis. You can see that the curves are about the same. So whether you see it on a ultrasound or whether you require paracentesis, um, your transplant-free survival is diminished compared to those who don't have ascites. So we'll start at those. Can we identify those who might be at risk to prevent ascites from occurring? This is where this, I would say, within the liver community, this is a relatively newer phrase. To people that may be listening today, this may be old hat, but the idea of clinically significant portal hypertension is something that really came up after I finished my training. So in my mind, I still think of it as new. And what people realized was that if you have a hepatovenous pressure gradient that's greater than or equal to 10, that's when you can start to see it's like the harbinger of bad things to come. So if we can diagnose that and then sort of work on treating the liver disease or even treating the CSPH, we can prevent bad outcomes. In the US, we tend to use a combination of a platelet count and FibroScan rather than measuring HVPG directly. So in general, if the FibroScan is greater than 25 kPa, that rules in CSPH. So there's this sort of gray zone with a platelet count and kPa. But if it's below 15 and the platelets are above 150, that rules it out. So if someone has liver disease, obviously, if we treat their liver disease, we may be able to help them. And that includes preventing ascites. So in the colored text up here, I'm just showing you medications that we use commonly to treat liver disease. It's sofosbuvir, tenofovir, ursodiol. And I included naltrexone because what we're finding is that patients with alcohol-associated liver disease, if we treat their alcohol use disorder, we can prevent decompensation. So this was a study done through the VA hospital system in the United States. The reason I chose naltrexone is the most commonly used medication for treatment of the most studied within the liver space for treatment for AUD. And you can see here that those who had a treatment actually had a decrease in hepatic decompensations, a decrease in short-term mortality, and decrease in long-term mortality. So treating someone's AUD, though in the past people may have said, oh, that's, I'll leave that up to the primary care doctor or the addiction specialist. I've now taken this into my practice. And if I see a patient that has both a dual diagnosis of ALD and AUD, I'll use naltrexone. I'll ask them if they agree to it and begin treatment with it. This is a study this is an Italian study looking at patients, over 600 patients, and what their first decompensating event was. And if they achieved an etiologic cure, so that was, a lot of those medications I just showed in the last slide, they could reduce all sorts of bad outcomes. And so what they found was they could reduce ascites, HRS-AKI, ACLF, and encephalopathy, and decrease mortality. So individually, we see the medications decreasing that, and as a group, we see it too. Non-selective beta blockers have now become sort of common practice in preventing ascites, and this follows with the idea of being able to diagnose CSPH. What put this on the map was the Predesi study published in 2019 in The Lancet, and they enrolled patients that had compensated cirrhosis with CSPH, but they didn't have high-risk varices, and they either got a beta blocker or placebo. This was done in 8 centers in Spain from 2010 to 2013. And the composite endpoint was death or hepatic decompensation. Obviously, there's a very big difference between death and hepatic decompensation, but looking at the composite outcome, even with a small sample size, they looked at about 200 patients, they were able to show that composite outcome was improved. And this was mainly driven by the reduction in ascites. So by decreasing portal pressure, you could decrease ascites. And this is great. The BOP SPPP study in the UK will look at patients for they'll look at more patients for a slightly shorter time, but hoping to get confirmation of those results in the near future. I think, I talked a few slides ago about CSPH. I feel like this is the study that really solidified and put it on the map for reasons for treatment before. The study used propranolol and carvedilol. We tend to just, in our practice, we tend to just use carvedilol if the patient's blood pressure can tolerate it. And I still use nadolol if they have a lower blood pressure. All right, moving on. Diagnosis, eating, and furosemide, DEF. So how do we diagnose ascites? Most ascites is caused from cirrhosis, at least 75%. And when I'm working with my fellows, residents, and medical students, we talk about this high SAG, low protein. I'm showing you a composite graph from Lupe Garcia-Sau's chapter in Zakem and Boyer. I really like this because the high SAG, low protein, this wasn't sort of handed down from high. This is from a composite of studies showing that the patients where they knew they had the diagnosis, and here is sort of a SAG. This line is 1.1. That's why we got that magical 1.1 number. And here's where cirrhosis is. You can see there are, hundreds of, over 100 patients here. And there's even a few that are just on the border there. So, if you have a high SAG, and then here's cardiac ascites, also above 1.1. But what they used as their non-high SAG was peritoneal carcinomatosis. So patients that have cancer will tend to not have a high SAG. And then when you're trying to determine between cardiac ascites and cirrhosis, that's where the total protein comes in. And if you have cardiac ascites, it's going to be above that 2.5 line. However, with cirrhosis, sometimes you can see patients above that 2.5. Here, you even see a 6. So just if they have high SAG and low protein, yes, it is going to be from their liver. But if they have high SAG and high protein, sometimes it could be from the liver. So you need to understand where the data comes from. These papers from the early 90s and paper from the 80s. And then use your clinical context to determine that. The low salt diet. What does this mean? I tell my patients this all the time with cirrhosis. And I feel like before I was researching this talk, I did a poor job. I think I'm doing a better job on talking about diet with my patients that have liver disease, advanced liver disease. Does it work? And if it does work, what are the consequences? So it's telling someone they have a low salt diet. If they follow it to the T, there are some things that can result from that. What does it mean? I guess I'm really showing some American things. This is a person, if they went and got a loaded hot dog at a baseball game in the summer, that would have almost an entire day's worth of sodium. So we say that someone should have 2,000 milligrams, or that's 2 grams of sodium in a day, or 90 millimoles. I never measure my sodium in millimoles, so we're just going to go by grams. But you can see that a hot dog probably has about that. And if you do that, you're not just getting the hot dog, you're probably getting what else it comes with too. So, that one small meal snack would be an entire day's worth of salt. Here's a piece of pizza that has 600 milligrams. People aren't usually eating just one piece of pizza too. So these are foods that people need to avoid if they have ascites. They're really going to be feeling it the next day. Legs might be a little bit bigger, put on a few pounds, and belly might be a little bigger. I'm using a lot. The Italians have really done a lot of great work in ascites, and I like this study. This was done published 10 years ago, and what they did was they asked patients prospectively in their clinic, patients with liver disease, do you follow a low salt diet or do you not follow a low salt diet? And then they also had them keep a diet diary for a few weeks. And what they found is it split into 3 groups. Group A, these were patients that said they followed a low salt diet, and they did follow a low salt diet. But group B was people who didn't follow a low salt diet. Now, the difference in B1 and B2 is that people in B1 thought they were following a low salt diet. I'm sorry, people in B1 didn't think they were following a low salt diet, but people in B2 did. So just because you say you're following low salt diet doesn't necessarily mean you are. So you have about a 50% chance. You're 29-37, so maybe 40-60. But there's a big difference. Even people who think they're following a low salt diet may not be following a low salt diet. So this is where this was eye-opening to me, was that, oh yeah, sure. What people will usually say is, I don't put salt on my food, but that doesn't mean they're not eating salty food. So it's important that you go over what is a salty food and what isn't, how you read a label. And so what I often do now is I'll have people do meal recall in the clinic with me. Simple, what did you have for lunch? I use breakfast. People don't usually have salty meals, but lunch and dinner, it's pretty salty. The ways to decrease that is, in general, food at restaurants or food that you get from delivery is going to be high in salt. Those restaurants want you to come back to them. Salt makes most things taste good. Should you have no salt? No, you can have up to 2 grams, but you need to be really careful. The lower the salt, the less likely you're going to have fluid accumulation. Does the low salt diet work? Yes. This study was done over 40 years ago, but it's still pretty great. I don't necessarily think it's something that would be repeated, nor does it need to be. The data is there. So this was done in France, and patients were in the hospital for 14 days on a salt-restricted diet or an unrestricted diet. And what they found was, on the salt-restricted diet, a lot of things about fluid retention and ascites improve. So we see weight loss, decrease in abdominal girth, improvement in appetite, and the amount of diuretics needed were less. So it does happen. It does work there. But what are the consequences? So that same paper I showed you 2 slides ago about the low salt diet also showed that those who follow the low salt diet tend not to get enough calories. Our patients with ascites need a lot of calories. There's typically comorbid malnutrition, sarcopenia. So neither one of these groups is actually getting at 2,000 calories or more in a day on average. And particularly the low salt group is getting, is getting only 65% of that. So not only do I talk to my patients about low salt, I talk to them about eating high calorie foods, which is a little bit of an inverse of what I'm talking to my patients with MASH and MASLD who don't have ascites. So depending on the context, I may be telling someone, no, you need more calories. And then someone who doesn't have decompensations, I'm saying, no, you need to have fewer calories. So I don't think it throws patients for a loop yet, but at some point they may say, didn't you tell me a few years ago I need to do this? That may be true, but things can change. So our patients with ascites really do need more calories. It is it is tough to keep up with the calories with ascites, but it's sort of as important as providing medications. I include this more for historical reasons. Head out water immersion, or the simple way you can call it a bath. There were studies years ago about what you can, if you have an edematous state, whether it's heart failure or cirrhosis with ascites, being in water actually can decrease your renin and aldosterone and lead to, really, it leads to urination. Make sure you get out of the tub or the pool before you do it. But it works in the same way that the diuretics that we use work. So here's just sort of the pathway. Head out water immersion. It tells your baroreceptors, oh, I've increased my central volume, and you can see decreased renin release, angiotensin, aldosterone secretion, and it decreases your absorption of sodium, and then you're going to excrete sodium. So this should look familiar to you, because this is where spironolactone works. This is where furosemide works. Now, if you are one step ahead of me, you might say, well, don't ACE inhibitors and ARBs, don't they work up here? Why are we not using those for cirrhosis? It's really because not only do they decrease those, they also decrease blood flow to the kidneys. And that seems to be the bigger problem for patients with cirrhosis is if you block it up here with lisinopril or losartan, you're actually going to cause an AKI. Whereas if you block down here, you're not. But I also encourage my patients, particularly when it's warmer, to be in the pool more or take more baths. All right. Hopefully this works okay for this audience, but I make a joke about the 10 commandments, that spironolactone, 100 milligrams, and furosemide, 40 milligrams, were given out by Moses at Mount Sinai. So just the idea that this is so ingrained in our medical teaching as what you give for diuretics that it's important to understand that no, this is just sort of a starting point that works for most people. But most of my patients are not on these two medications at these two doses. And in fact, I use a variety of doses of spironolactone and use it with or without a loop diuretic. And I hope after I explain some of this, you will too. So for mild and moderate ascites, you can actually use spironolactone alone. So this was a study in Spain, single center, where they took patients that had grade 2 ascites. So it's in general, it does require medications, but does not usually require large volume paracentesis. You can see their belly's a little bit bigger. They may complain to you of some abdominal distension, but you don't need to stick a needle in there. And they took 100 patients, about 100 patients. I think a few dropped out. And they randomized patients to spironolactone and furosemide or spironolactone alone. And they would increase diuretics every 4 days to achieve grade 1 ascites. So ascites you couldn't see on exam. And what they found was while your body weight, you could decrease it a little bit quicker or a little bit more with the combination diuretics. It worked about a half a day quicker. But if you look at response or mobilization, they're about the same. The side effects about the same. But what you notice, the differences between the two are that you were more likely to need to reduce the diuretic dose if you gave them two diuretics, as opposed to if you just gave them spironolactone. You give them spironolactone and they can just stay on that same dose. It does usually require a higher dose of spironolactone to achieve diuresis compared to when you use dual diuretics. But we often see fewer AKIs with spironolactone alone. What about those other diuretics that we use, like eplerenone or maybe bumetanide and torsemide? So eplerenone, it works about as well as spironolactone. The reason I started using eplerenone more was it became generic in the United States, so it doesn't cost quite as much. When I was in training, it was still on brand, so it cost so much more than spironolactone. The reason I make the switch, it's usually in men, and spironolactone can cause gynecomastia in about 20% of men, maybe even up to 30. So I often ask my patients, particularly male patients, if they're on spironolactone, if they're having any chest or breast discomfort, and if they say yes, I'll switch them. This tends not to bother women, but if they say that they have breast discomfort, then I will switch them too. This was just showing that 100 milligrams of eplerenone is about as potent as spironolactone 100. What the half-life is slightly shorter, so sometimes you'll need twice daily eplerenone as opposed to once daily spironolactone. What about making the switch from furosemide to either bumetanide or torsemide? Just know that torsemide and bumetanide, they're more potent. They last a little bit longer. So if you need to remove more fluid by a diuresis, then reach for those. Just know that they're more likely to get an AKI. When I'm making the switch from bumetanide, from furosemide to bumetanide or torsemide, it's usually a signal to me that the patient's liver disease is advancing and they may need a paracentesis or become paracentesis dependent in the near future. Or they're taking in more salt than they should. So it goes back to that, talking about salt. What about long-term albumin infusion? So this was a great study that took patients with diuretic responsive ascites and either gave them albumin at regular intervals or standard medical treatment. And what they found was they could actually improve survival. And this was driven mostly by time to first paracent. So they improved survival, but really they could improve the development of refractory ascites. And refractory ascites is a harbinger of death. There should be some follow-up studies related, but this is the best study so far to show the impacts of albumin on patients with diuretic responsive ascites. All right, moving on. RST, refractory ascites, spontaneous bacterial peritonitis, and thoracentesis for your hepatic hydrothorax. All right. So another part, sort of that's ingrained in my medical training is if you're taking more than 5 liters off from a paracentesis, we need to give someone albumin back. Um, for a while, our interventional radiologists didn't always do this, but I think, after 40 years of this being standard of care, I see it at pretty much any place my patients get a paracentesis. So this is great. This is sort of to set the table for when we talk about large volume ascites, what are we talking about? Grade 3 ascites, so in general, this is large ascites that can't be mobilized, or it recurs after a large volume paracentesis. We have recurrent ascites, which is not the same as refractory ascites, but they're similar. So this recurs at least 3 times a year, despite diuretics and sodium restriction. And then we have refractory ascites. We have 2, diuretic resistant and diuretic intractable. Though we tend to use the term diuretic resistant most often, most patients don't actually have diuretic resistant ascites. They tend to have ascites that's diuretic intractable. We tend to stop their diuretics or decrease their doses because of side effects. It could be cramping. It could be their sodium or their creatinine or their potassium or their bicarb get too high, or so any of these things can happen. Diuretic resistant is you have to be reaching really high doses of diuretics, and then they still have ascites. Most of the time, that's also from not following salt restriction too. It's usually a combination. In general, when we think about this, patients can sort of have a number of these. All right, recurrent ascites. This is really should think about tips. On the left, I have sort of contraindications. So I don't place as many tips as I would like. I think they can work really well if you place them early in the right patient. And who is the right patient? They tend to be younger than 60, without encephalopathy. They tend to have a lower MELD, less than 18. They shouldn't have any of these things up here: heart failure, uncontrolled infection, portal vein thrombosis. You can actually, depending on the radiologist, they may be able to place one. This is one of the original studies up here in the top right. You looked at overall survival. It with an uncovered tips versus paracentesis, and they found it was about the same. On the bottom right is a French study that showed that tips in the modern era actually did much better. I think it's somewhere in between. I do think this survival is a little bit too good for what I'm actually seeing. I mean, this is pretty incredible versus LVP, but I do think there's probably some survival benefit. I just don't know. It's probably somewhere in between these two. Who should we provide a tips to? So this is going into some sort of medical history on the MELD model. It was developed at Mayo Clinic and was originally used to determine who should get a TIPS and who shouldn't. And what they used in the original model was total bilirubin, creatinine, their disease. And this was whether, they looked at, it was dichotomous. They looked at alcohol, I think, hepatitis, and then none of and then cholestatic disease. And they divided them into high risk and low risk. And if you were low risk, great, go forward with the tips. If you were high risk, that was a bad idea. You were going to die after the tips. So and then this converted into what we think of as the classic MELD of 18. So often if I refer a patient for a tips and their original MELD is greater than 18, the radiologist I work with will tell me, do you really want to do this? And often I've thought about it and said yes, because we've come, we've moved, we've advanced from just using the original MELD for safety of tips, and we now have this thing called the FIPS, the Freiberg Index. And what this does is it has a lot of the same variables. You still have creatinine and bilirubin, but it adds back albumin and age. And this is something we've been seeing for years. Older patients did worse with the tips. And so now it actually is placed into the model. And the other thing is patients who have very low albumin also do worse with the tips. So the albumin really, it's a marker of the extent of, or sort of the extent of their liver disease, sort of where they are. And so the lower albumin, those patients tend to do worse. And here I put the link if you want to look at the tips. What about the timing? This was a retrospective study, but I'm showing it here to prove a point, is that the LVP frequency prior to the tips will predict whether you develop ascites after your tips. So patients who had controlled ascites with the tips tended to have fewer paracenteses before, about almost 2.5 a month or 2.2 a month versus 3.6 a month. It's hard to get above, those are patients going almost weekly, whereas the other ones were going about every other week. And if you have controlled ascites after the tips, that is what's going to predict your post-tip survival. So really, you want to now, could there be lead time bias? Of course, but you're also thinking about quality of life. So if someone has indications for a TIPS and doesn't meet contraindications, you really should be talking to your patients about TIPS rather than letting them go for paracentesis again and again and again. Patients will say, I don't want a TIPS because it can cause encephalopathy. They won't use that term encephalopathy, but they'll say, things like, I don't want to be confused, or I don't want my brain. I want my brain to keep working, and I do too. So, there was a really interesting study a few years ago showing that instead of dilating the tips, if we placed the tips, but then just kept it undilated or underdilated, rather than 8 millimeters, use 6 millimeters, those patients had less encephalopathy post-tips. So there's actually an ongoing study that we were a part of at Penn, BD Arch, where they start the tips at 6 millimeters, and then it can be dilated up to 10 as needed. So we'll get the results of that at some point. How do we prevent encephalopathy after a TIPS? I wish lactulose helped. There isn't great data on lactulose in preventing TIPS encephalopathy, but we do use it. But there is some good data on rifaximin. This is from the Annals of Internal Medicine. This was done in France. And there were patients were given rifaximin or placebo after their TIPS. And you do see that there was more, after 24 weeks, they were more likely to develop overt hepatic encephalopathy if they had placebo rather than rifaximin. And the number needed to treat is actually pretty good here. All right. This isn't in standard treatment yet, but there's sort of a groundbreaking group in Melbourne, Australia, in the Victorian Liver Transplant Unit that's been really the forerunners of using continuous terlipressin for patients on their waiting list. And they'd had some publications over a few years, case reports and such, but this was the most recent study, really great study, where they had 30 patients and they did a crossover study. I love a crossover study because patients can serve as their own control. So they got continuous terlipressin infusion for 12 weeks and standard of care for 12 weeks. And then they compared the patients, how they did themselves. And they got terlipressin 4 milligrams delivered over 24 hours via PIC. There were some complications. Most of the complications were related to the PIC line. Terlipressin itself didn't cause much complications in these patients. And what they found was hand grip strength improved, the number of paracenteses decreased, and the total volume of paracenteses decreased a lot. So it's not a panacea, but you can improve. Someone who normally goes once a week may only go every other week. I mean, so that's pretty great. And so for patients waiting for the transplant that are leery of a TIPS, this is a great alternative if it's available. What about the Denver shunt or the PV shunt? We place these at my institution sometimes. We have some people who are good at this and have been doing it for a long time. This was done in the bad old days before TIPS in the 70s. They do have poor long-term patency, but this is a study that I worked on with one of our medical students and our radiologists years ago, just looking at patients that had TIPS versus we actually had an LVP arm too, and those who got a Denver shunt, and we propensity matched them, and we found that they worked. TIPS and Denver shunt worked about as well for controlling ascites. And you could keep people out of the hospital with people had less sort of emergency room and hospital visits if they had ascites and they underwent a Denver shunt. Who gets the Denver shunt? It is a different population. They tend to be older. They tend to be older. These are patients that tend to have more liver cancer, and they also tend to have MASH or MASSOLD. And this is probably due to the fact that we felt that maybe they were poor candidates for TIPS. But it is I would say, but Denver shunt is an underused treatment for ascites. What about the alpha pump? So this is very exciting. This was approved in the EUA in 2013, and recently I had to change my talk a little bit. This was a FDA approved in the United States as of last month. So the alpha pump, so I know I'm talking to a global audience, so this may not be available where you are, and hopefully one day it may be, because there's certain patients that can really benefit from the alpha pump. What is the alpha pump? So there's a little motor that's it's a pump that's placed in subcutaneously by interventional radiologists or surgeons, and there's two arms. There's one catheter that goes from the ascites up into the pump, and then from the pump there's another catheter that goes into the bladder. It does take some time to recover. There can be a little bit of pain. It does take, and what this pump is, it's a smart pump in the sense that you can adjust it to determine for how much ascites that person's producing. It does decrease paracentesis needs dramatically, and there also is a signal for improvement in nutrition as measured by prealbumin. All right, the last of my 10 commandments. This is how do you diagnose SBP? So this is based on neutrophil count in the ascites greater than or equal to 250. And so I feel like my medical students can rattle this off. So how do we treat it? The standard of care is a third-generation cephalosporin. But you need to understand the context. If someone's really ill with SBP, like if their Cliff SOPA score is greater than 7, I wouldn't go for ceftriaxone first. You probably want to use a carbapenem first line. And that's based on this study just showing what the likelihood of death is if you use a third-generation cephalosporin versus a carbapenem. Piano did a great study looking at nosocomial SBP. So if someone develops SBP when they're already in the hospital, reach for the big guns and start with daptomycin and meropenem. You can peel one or the other off, but you need to sort of, it's sort of all hands on deck with that one. What about SBP prophylaxis? I feel like the pendulum keeps swinging back and forth on this one. Now, there is no doubt that if you have had SBP in the past, you need secondary prophylaxis. So those patients, you've had it before, you should be on prophylaxis. What about primary prophylaxis? Right now, we recommend it. We recommend it to people at high risk of getting SBP, that it would include patients with a low protein count in their ascites, with maybe they have CKD, maybe they have hyponatremia, or they're a child B9 or C, or high bilirubin. Tend to use ciprofloxacin or TMP SMX. It's until transplant death or ascites resolution. So if someone has recompensated, they don't need to be on SBP prophylaxis anymore. But there are some cons. And while sometimes in some patients it may improve their morbidity and mortality, you have to be careful with the side effects of a long-term fluoroquinolone. But also it can increase their multi-drug resistant organisms. This was a study done from the VA looking at first SBP, and those who are not on primary prophylaxis were less likely to have resistance, and those who were on prophylaxis were more likely to have a resistant organism. So I feel like I debate, this is, of all the things on my talk, the two things that I debate most with my colleagues are SBP prophylaxis and low salt diet. So I have some colleagues who feel that the nutrition aspect is so important for the low salt diet that you shouldn't worry about it. But for SBP prophylaxis, my feeling is it can decrease the sort of medium-term mortality, so we have to use it. And the cost is really that in the long term, you may develop a multi-drug resistant organism. However, if you aren't on it, you may not get to that point to develop that multi-drug resistant organism. What it really means is if you need SBP prophylaxis, it is those we're at the point where patients really need a transplant conversation if you can have one. What about hepatic hydrothorax? These are so much harder to deal with than a patient that requires a large volume paracentesis. And if they don't respond to diuretics, TIPS is your answer. There are not many studies looking at this. This was the best that I could find, but it does show that after a while, at least half of patients in this cohort had controlled controlled hydrothorax after 6 months after a TIPS. And these numbers were somewhat comparable to ascites management, but you do see that more patients didn't have a response in this study if they got it for hepatic hydrothorax. All right, last one is the hepatorenal syndrome. So again, similar to CSPH, some nomenclature changes have occurred over the past 10 years. I think people now are not using the old nomenclature, but I always like to talk about this. We used to talk about HRS1, HRS2, acute or chronic, and now we have HRS-AKI, HRS-AKD, and HRS-CKD. So the way I tell my sort of trainees is, and I get this consult from services all the time. Patient comes with cirrhosis and they have an AKI. Is it HRS? Usually it's not. They have to have ascites to have HRS. If they don't have ascites, they don't have HRS. And usually, but not always, it is large volume ascites, where this isn't someone who just got ascites. Now, ALK-HEP, sometimes you can see hepatorenal syndrome and it can be associated with it, but those patients tend to have larger volume ascites. They also, their AKI can also be from other things. So you have to take that into account. But the AKI, it has to meet these criteria. It can't be responsive to diuretic withdrawal, volume expansion, and you can't explain it by another diagnosis. Now, one of those diagnoses could be biocast nephropathy. That's a tough one. But if someone's bilirubin is 50 and they don't have much ascites, it's probably not HRS. In the US, terlipressin was approved in September of 22. I think, we're the last people to get this. I think most of the people that may be listening to this have been using terlipressin and using it well for a long time. AKI and cirrhosis and HRS really is a separate talk. And so I don't have too much more on that. So takeaway points from my talk today. The best treatment of ascites is prevention. If you can prevent ascites, your patient won't be thanking you, but they should be. Low salt diet, teach your patients about this. If you don't feel comfortable, you should have them see a nutritionist so they can talk more about it. More baths. We can use non-pharmacologic treatments for our patients with ascites. So if they have access to a pool, tell them to go swimming more. Just hang out in the pool. Eplerenone is not cost prohibitive. So if a patient is telling you they're having some breast tenderness or chest tenderness from spironolactone, you can switch them. Bumetanide and torsemide are more potent than furosemide. So, if patients aren't getting the bang for their buck with furosemide, you can switch them. Place the TIPS early after they've developed large volume or refractory ascites. You can tell the person who places the TIPS about the small bore TIPS, so not to dilate, and maybe it can decrease their encephalopathy. And primary SBP prophylaxis, it's not as straightforward as we think. There is a study that is ongoing in the UK that may help answer this. And thank you. On the left is this is a research team at Penn, and then this is me on vacation with my family in Joshua Tree last year. So everyone who signed in on Saturday, I thank you, and I'm happy to take a number of questions.